Okay, I think I'll just check if I could. Oh, my pen. Sorry.
Is there a red pen on the table? Red pen. It's okay.
Okay, and thanks very much, Mitsuko. That was the most amazing talk that was given by Nguyen, and probably the vet. Oh, you found it. Good man. Thanks so much. Yeah, thanks very much. Thank you. That was the most amazing talk given by Nguyen, and the best talk that I've seen given on that subject ever. So I'd like to congratulate you. Fantastic. My talk is a much easier talk than Nguyen's. I'm very glad I didn't give that talk, Nguyen. Mine is on agenesis of the corpus callosum, and exactly as Mitsuko just said, it's extremely controversial. And if you look at Australia as to what is happening now, is that at the mid-trimester examination, there is now a move to examining the corpus callosum on sagittal imaging in every patient. Is that what you are doing? Are you just relying on axial imaging of the brain in 20 weeks? Or like Nguyen, are you examining every baby at 20 weeks by sagittal imaging to directly see the corpus callosum? And let me ask you, do you know what are the ISUOC guidelines? What does ISUOC say about imaging the corpus callosum at a routine scan at 20 weeks of gestation? So I want to go through the talk by covering the introduction of the Delphi consensus, of which Mitsuko was an author and which I was a collaborator. And what does the Delphi consensus say? And does it conflict or agree with the ISUOC guidelines in examining the brain? I'd then like to talk about the normal corpus callosum and about how to measure, or if to measure, the corpus callosum. And then I'd like to talk about how you make a diagnosis of agenesis of the corpus callosum. I'll talk about axial imaging and then direct imaging of the corpus callosum, and then I'll finish with a summary and some take-home messages. So, I want to ask the audience a question. You are all familiar with ISUOC guidelines. They are very important. They direct us what to do in routine clinical practice. This is the ISUOC guideline for evaluating the brain in screening, which is part 1. And the ISUOC guidelines for examining the brain in diagnosis for the fetal neuro experts, it's part 2. But part 1 refers to 99% of doctors who are screening sonographers. And let me ask you a question. Does ISUOC guidelines recommend examining the corpus callosum as part of a routine screening examination? Yes or no? I heard somebody say no.
No.
And they're right. ISUOC guidelines do not recommend examining the corpus callosum as part of a routine examination. No recommendation to image the corpus callosum. But the world is changing very fast. And it takes a long time before ISUOC comes out with a guideline. And now in Australia, We are not following the ACO guidelines and screening. We are moving to routinely imaging the corpus callosum in every pregnancy. And the same is happening in Vietnam. So you need to ask yourself the question, what am I doing and what should I be doing? And what risk do I take by not examining every baby in sagittal imaging of the brain? The Delphi consensus, which was very recently published, addressed this question because at every meeting around the world there was a growing consensus that every pregnancy should have the corpus callosum examined on sagittal imaging. And on that paper on the Delphi consensus, I ask you a question. At routine 18-20-week mid-trimester examination, should sagittal imaging of the corpus callosum be obtained in every case? This was the question that was put to me as a collaborator, questions that were created by Ritsuko and co-authors, and asked the experts around the globe whether that should be the case. And it also asked the question at the routine 18-20-week mid-trimester scan, should the corpus callosum be routinely measured? Or is it just okay just to see it and not measure? And if the corpus callosum appears abnormal in screening, does this mean automatically it should be measured before you refer the patient on? And if a satisfactory sagittal view cannot be obtained, you can't get it because of either inexperience, technical difficulties, position of the baby not being in correct position, patient being of a large BMI, the gestation only being 18 weeks, should you bring the patient back for another scan because you didn't see the corpus callosum? So what do? Do you say, no, I couldn't see it. That's it, finished. The other questions which the Delphi consensus suggested in the diagnostic setting, part 2 of the ACO guidelines, when the baby's encephalic presentation, should a transvaginal scan be performed in all cases? So, if you are a specialist performing a fetal neurosonogram and you think you see everything transabdominally, it's all very clear. Should you do a vaginal scan? Yes or no? And in the diagnostic context, when the corpus callosum abnormalis is suspected, is it okay just to look at 2D? Or if you are the specialist, should you do 3D? And if the corpus callosum appears subjectively abnormal on the diagnostic, should it be measured? Or do you just take your subjective assessment as an expert? And if there's inadequate sagittal imaging that you can't obtain as a specialist, you do a transvaginal scan, can't get the perfect image. Should you bring the patient back? Or should you just say, listen, I tried to look, I think it was okay. Or maybe I can't see it, doesn't matter, continue the pregnancy. And when assessing a possibly short corpus callosum, should clinicians rely on just one length? Or should they consider other measurements, looking at the inner occipital to frontal diameter, comparing the corpus callosum length? If you have not read the Delphi consensus, I think you need to read it. I'm going to give you the answers to all of these questions at the very last slide. But I say these questions and put them to you to make you think about what you're doing and what you should consider doing in routine screening. And before I give you the answers, I want to walk through some of the subtleties, the challenges that exist in diagnosis. And the next part, I want to ask you a question which becomes very relevant in the new world of genomic screening, is to what proportion of babies who have just isolated agenesis of the corpus callosum, what proportion of these have got a single gene mutation? So in other words, you do a chromosomal microarray and it comes back normal. Should I do an exome? Well, it depends what the prevalence is. You say, well, what about 1 to 5%? Do you think it's 1 to 5%? Or do you think it's less than that? Just isolated agenesis. Do you think it's 15%? Do you think it's 20%? Do you think 1 in 5 babies with isolated agenesis have got a single gene mutation? Or do you think it's a quarter? The answer is a quarter of babies with isolated agenesis have got a single gene disorder. So we are routinely, as soon as we make the diagnosis of agenesis, we are starting the process of exome sequencing. Not waiting for doing an amnio and a fish and it comes on a microarray, because you've lost 3 weeks by the time you get your CNA. So, brain abnormalities in general, not just isolated agenesis of corpus callosum, have a high, strong association with single gene disorders. In fact, if you look at it, if you have ACC, agenesis plus an extracranial abnormality, half of these will have a single gene disorder. If you look at ACC and other cranial abnormalities, 43%. So if I see polydactyly and ACC, if I see a facial cleft and ACC, if I see a tiny omphalocele and ACC, there's a 1 in 2 chance that that baby will have a single gene disorder, and I need to do wide exome sequencing. So you see how important it is to make a diagnosis of agenesis of the corpus callosum, and then how important it is to do a very detailed evaluation in this new world of single gene testing. I want to move next to imaging the corpus callosum, and myself and Ritsuko will do this in live scan. But anytime I go to image the corpus callosum, I try and get this view where I see the sandwich. And that's the image of the genu. And once I have the image of the genu going through the anterior horn, I rotate the probe 90 degrees, keeping the genu in view. That's a practical approach how to get it in view. And if I'm coming through the posterior fontanelle, I see the genu, and I look back towards the spleen. And then I rotate 90 degrees. So either come through the anterior or the posterior fontanelle to come into view. The second practical point is that when imaging the corpus callosum, it's important that when you keep it in view and you rotate on the sandwich, you rotate until you bring the vermis into view. And I have to have the vermis in view to ensure that I am not oblique. Because if I am oblique, I am going to create a short corpus callosum. I aim to get the fastigial point and the corpus callosum in the same section. That is so important in routine imaging, and making sure that you have 2 reference points. The anterior reference point, the genu and the anterior body, and the posterior reference point, the vermis. If we look at the issue of guidelines, we all know in this room there are 3 sections: transventricular, transthalamic, and transcerebellar. I don't know if you realize that when you look at the issue of guideline, that every single plane includes the CSP, because you have to have an anterior landmark and a posterior landmark for these 3 standard planes. It is obligatory when you're looking at the cerebellum and taking a measurement that you have the CSP in view. It is obligatory when you're looking at the lateral ventricles that you have the CSP in view. Anterior and posterior landmark. You have to do that in routine clinical practice. It forces you to look at the CSP. Nguyen has given a beautiful demonstration of all the abnormalities of the CSP. And she's also elaborated on the next step, which is looking at the anterior complex, which is made up of the valves anteriorly, the genu, the pericallosal sulcus, the medial wall, the lateral ventricle, the anterior horns, and the cadence septum pellucidum. These are the 5 components of the anterior complex. So when you go to work tomorrow morning, don't just look at the CSP. you need to look at these 5 components and ask yourself, am I seeing all these 5 components? So you magnify the image of the anterior complex. You see the phallus, the pericallosal sulcus, the medial wall of the lateral ventricle, curving towards the leaves of the cavum septum and the tilea, corellia, and here the phallus. This is the distance you measure, including the genu, when you're doing your CSP index. Nobody mentions this in the guidelines, and I think it's an omission in the guidelines. But when you are looking at the medial wall of the lateral ventricle, understand that it has a curve like the letter S. You need to understand the curve of the medial wall of the lateral ventricle and look at it at every scan you do, because it is a very powerful tool in helping you detect agenesis. When you are looking on color Doppler evaluation, I would suggest using slow flow evaluation, because it very quickly will demonstrate the pericallosal artery. When looking with 3D examination, I would suggest that you look with 3D, with volume speckle production imaging at 5, and if you want also volume contrast imaging at a mid-trimester of 2 millimeters. There are 2 practical points. I'm going to be very quick on talking about the biometry, because in the Delphi consensus, there was no consensus as to which chart should be used. So if you look at the measurements that have been taken in 2D, 3D, and MRI, there are so many charts. And when you look at the charts, there are wide variation in the measurements of the charts. I was asked in the Delphi consensus as to which chart I felt was the best chart, and this is the chart I use. And maybe Ritsuko, I happen to ask Ritsuko which one she uses, but this is the one that I felt is the best chart because it included 2,950 fetuses and it was prospective. And most of the numbers of our patients recruited were exactly at the gestation we do our mid-trimester examination. Pietro Segnini's chart. And that sits on the wall in our practice when we're worried about corpus callosum abnormalities. If you are doing 3D evaluation, do not use Pietro Segnini's chart. You need to do the chart in which a 3D construction reference range was constructed. Use that chart. So, this is Pietro Segnini's chart at 20 weeks of gestation, looking at a mean of 21 millimeters. This is the patient 20 weeks and 4 days, and the corpus callosum measures 12 millimeters. If you look, the inexperienced operator in this room may think that corpus callosum is normal. But when you measure that and you see that the measurement of that is only 12 millimeters, when you know it should be 21, you can see that that's terribly abnormal. But what was a very useful take-home message from the Delphi consensus was that one of the best measurements which has been neglected over the years is to take the occipital frontal diameter and reference the size of the corpus callosum to the occipital frontal diameter. You can see that the corpus callosum looks about 1/5 of the occipital frontal diameter, when you know it should be about 2.3 in terms of the reference of the length, the occipital frontal diameter. So if you don't measure anything, simply look at the length and refer to the occipital frontal diameter. There's also a very practical point, that when you're trying to work out whether the rostrum, the genu, the body, and the splenium are present, turn on Doppler and look at the great cerebral vein. So that will define the end point of the corpus callosum and the pericallosal artery. And that will allow you to then take a measurement. Again, in a baby with a severely shortened corpus callosum. This is from Gray's Anatomy, showing the pericallosal artery that comes down and meets the great cerebral vein, the lateral cerebral or left cerebral vein. Again, slow flow Doppler. In a baby here with a thick corpus callosum, you can see it comes down and joins the left cerebral vein. It allows me to define the endpoints of of the corpus callosum measurement. I then now am going to run through very quickly complete agenesis of the corpus callosum. And let me give you some good news, that for almost every single case of complete agenesis of the corpus callosum, you can make a diagnosis on axial imaging, or raise suspicion on axial imaging. This is not the case for partial agenesis, but it is for complete. And that's why Isuov makes a call of non-direct visualization. We could discuss it in Q&A. I'm going to go very quickly now to the rest of my talk. So, number one, before you get the lateral ventricles, the interhemispheric distance is increased. Patient number 1, 16 weeks. The falx is thickened. Patient number 2, at 19 weeks. Increased interhemispheric distance. Patient number 3, increased interhemispheric distance. You also know there are multiple lines. Patient number 4, increased interhemispheric distance. You will also notice that there are multiple lines. So before you even get to the lateral ventricles high up in the brain, you see multiple lines in the midline. This is a very useful clue that there's a problem. Before you get to the lateral ventricles, you may see that there are increased sulcations. This is very high axial section. This may be a clue before you even get to the Isuov guidelines, looking at the 3 sections. The transventricular, transthalamic plane. So here you look at this, and you will see that the CSP is absent. And here also you see the CSP is absent. But be very careful, because when you look in some cases, you see a midline cyst that looks like a CSP. This is not a CSP. A midline cyst is a marker for agenesis. Let me ask you a question. What percentages of fetuses with ACC present with ventriculomegaly at the mid-trimester? Because there are some doctors who say, I don't worry about ACC at mid-trimester because I know I'm going to see ventriculomegaly. It's okay, I can pick up ventriculomegaly. But what percentage of babies with ACC present with ventriculomegaly at 8 to 20 weeks? Is it 100%? Is it 80%? Is it 70%? Is it 50%? Is it 30%? Is it 25%? Does anybody know? It's 25%. So most babies with agenesis of the corpus callosum at your mid-trimester scan are going to have normal lateral ventricles. In the 3rd trimester, it's 75% of babies are going to have ventriculomegaly. And therefore, you cannot rely on that as the sole finding. 25% less than 24, 75% greater than 24. So yes, if it's present, it is a useful clue, as Newen has pointed out. In both of these babies with ventriculomegaly, and the ventriculomegaly in the 3rd trimester will be more severe. Then there's the shape of the ventricles. It will be a teardrop shape. This is well described in both the 2nd and the 3rd trimester. They look like a teardrop shape. Then when you look at the distance between the anterior horn and the midline, which is A, and you measure the distance between the lateral ventricle and the midline as B, is A is greater than B. That is the reverse of normal. And then when you look at the curvature of a normal baby, whereas a baby with agenesis of the corpus callosum, the medial wall of the lateral ventricle is straight. And that's also a very useful indirect clue that you're looking at agenesis of the corpus callosum. And when you look in the midline anteriorly, you see this bundle of tissue, and here's your anterior horn. That's called the bundle of Prost. And the bundle of Prost can be another axial marker. Here's your anterior horn. And you can visualize the bundle of Prost, especially in 3D volume examination. And then you will see an interhemispheric cyst, which exists in a significant proportion of babies with agenesis of the corpus callosum. And sometimes the position of the cyst may be exactly in the region of the corpus callosum, in the region of the CSP. You think, it's okay, the CSP is present. It is not the CSP. It is a cyst. And don't confuse them. And some of the cysts may be striking in this baby with agenesis, with multiple cysts in the midline. Again, you ask the association that you see these cysts, are they arachnoid cysts coexisting, or are they interhemispheric cysts, part of ACC? And then lastly, pericallosal lipomas. Again, a strong association with ACC does not mean they have ACC, but it means you need to look to see whether they've got agenesis. And then lastly, the transthalamic, you're looking for dilatation of the third ventricle and elevation of the third ventricle. So there are 4 sections from top to bottom that will demonstrate all these signs. But you do not have a diagnosis. Your next step is then to move to coronal, sagittal, and parasagittal. Very quickly, in the second trimester, when you get your vermis in view, you cannot see the corpus callosum. And that's the key mark. And then you may look also for the pericallosum artery. In this case, in the second trimester, no midline corpus callosum. In the third trimester, it's easier because not only is there no pericallosum, you see no cingulate gyres, and then you see this radial burst appearance. You do not see that radial burst appearance of the sulci emanating from the midline in the second trimester because they haven't formed. It's a third trimester finding, sunburst appearance that's seen on both MR and on ultrasound. And your pericallosal artery is called absent. It's not so much as absent, but it's irregular and then it's chaotic. And then from there, you can move to more fancy technologies, looking with color Doppler, and then in all cases, we move to MRI, not to make the diagnosis, but rather to see if there isn't any coexistent abnormalities. So to finish up, the Delphi consensus recommends that in every case, that sagittal imaging of the corpus callosum should be obtained. If you are unable to visualize the corpus callosum, there is no reason to bring the patient back. And in terms of, you see the corpus callosum as being abnormal or short, you should not measure in the screening context. You need to refer on for a second opinion. The Delphi consensus agrees that in the setting of diagnosis, you routinely should perform a transvaginal scan. You should routinely do 3D imaging, but there was no consensus on which chart should be used. And if you are unable to get the image as an expert, you need to bring the patient back until you can get the correct image. And when you're looking at corpus callosum measurement, the recommendation is that you consider the internal cranial measurements, as I mentioned, reference to the corpus callosum neck. So it's important you consider that. So thank you very much for your attention.
Thank you.